Good afternoon and welcome to the second Melbourne Institute Colloquium for 2021. My name is Roger Wilkins and I'm the Deputy Director of the Melbourne Institute. Before we begin, I'd like to acknowledge the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respects to their elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islander peoples here today. These colloquia replace our normal face-to-face forums and workshops. Our goal is to provide insights of Melbourne Institute researchers and to also engage with you, the audience, so we can better understand Australian economic and social policy issues. Today we have Dr. Yang and Associate Professor Jongsay Yong, who will present their research on how competition in the residential aged care sector in Australia impacts on the quality of care and on prices. The talk will also compare the performance of for-profit versus not-for-profit and publicly owned aged care facilities. About our speakers, O is a research fellow at the Melbourne Institute. He obtained his PhD in econometrics from Monash University and specialises in health economics and econometrics. Prior to joining the Melbourne Institute, O worked for the Department of Health and Human Services as a senior statistical consultant. Jongsay holds a PhD in economics from the University of British Columbia in Canada. He joined the Melbourne Institute in 2002, specialising in empirical research on both health economics and industrial economics. He has conducted numerous studies of health services utilisation in the context of Australia's mixed public-private system, and he has had extensive experience analysing hospital administrative data, especially Victorian linked admitted patient data. He has participated as a key researcher in a number of commission projects, to date authoring 28 commission reports for government departments, non-profit organisations and private sector clients. O and Jongsay will speak for approximately 30 minutes. This will be followed by 10 to 15 minutes of for questions and comments from the audience that will be addressed by our two speakers. A note about how we're handling questions and comments. For those of you watching through Zoom, we are relying on the Q&A function found at the bottom of your screen. For those of you watching through Slido, you can submit questions in the box on the right-hand side of your screen. You can submit the questions at any time throughout the talk and then through these functions, and then I'll relay those questions to our speakers during the question and answer session. With that, I'll now hand over to O and Jongsay.
Thank you, Rogers. Let me share screen first. Before I start, I would like to acknowledge the contributions of our co-authors, Professor Yuding Zhang and Professor Tony Scott. So both of them are co-authors of our report, which we circulated as a working paper called Competition, Prices and Quality of Residential Aged Care in Australia. If you like a copy, you could visit our website and request a copy through the link there. Now, this study, I would like to also acknowledge the financial support by the NHMRC Partnership Center for Health System Sustainability, and also the support by the ARC Center of Excellence in Population Aging Research. Now, last but not least, we are very grateful to the Royal Commissions into Aged Care Quality and Safety for providing the data for this research, and especially to Grant Weitzman, Samuel Bai, and Thomas Pierce for their help in accessing the data, interpreting the data. So let's begin. Governments in many countries these days have been increasingly relying on competition and market to allocate resources in aged care. Australia is no exception. Since about 2012, 2013, since the passing of the Aged Care Act, competitions, consumer choice, markets have been key policy themes in government policy. Now, in principle, under the right conditions, competition should be able to promote efficiency, improve quality, lower costs, and so on. Now, you notice that the word right conditions are highlighted. That's because in a lot of discussions, they tend to be forgotten. The conditions are quite stringent in economics. You need many sellers, many buyers. You need information about quality and prices be freely available, and consumers should be able to move across to other providers without much cost. Now, all of this cannot be said to be true in the aged care market, and therefore, there's no surprise that market failures is something that we cannot ignore in aged care markets. Now, despite many years of market-oriented reforms in Australia, quality and safety in aged care continue to be a concern. We just had a Royal Commission's investigations that shows many problems with the aged care system, and the Commission has recommended a long list of recommendations to reform the system. Now, our objective today is very modest. We just want to investigate whether competition is associated with better quality of care and lower prices. To do that, we construct competition and price measures, and then we link these measures to a number of quality measures which cover multiple quality domains. And the analysis we use is regression analysis. For those who are interested, we just use simple OS with small area and time fixed effects. Now, the data we use are de-identified facility level data. So each unit of observation in the data, it's a facility, it's an aged care, residential aged care facility. Now, the data were accessed under contract from the Royal Commissions. The data period covers 2008 and then 2013-14 to 2018-19. There's a gap in the data simply because we didn't have any data during those periods. The analysis today will mostly using data between 2013-14 to 18-19. The data for 2008 and 9 is mostly for comparisons in the descriptive statistics. Now, the data cover about 2,900 facilities each year, and this include almost every residential aged care facilities in Australia. Now, to start, we need to construct competition measures, and we constructed 3 measures. The first is number of competing facilities within 10 kilometers. So this is just simply for each nursing home facility, we draw a radius of 10 kilometers and then count the number of competing facilities in this circle. The second is we measure the distance. For each facility, we measure the distance to the third closest competitor. Now, why the third closest is just an arbitrary number. We could measure 5th or 1st or whatever number we like. The results will be very highly correlated, so it's pretty much similar. The third is the most popular measure of competitions in the literature. It's called the Herfindahl-Hirschman Index, or HHI. Now, it is using the measure in the first measure, similar to the first measure, drawing a circle of 10 kilometers. But instead of counting, we look at the market shares of each facility. And the market share in this case is measured by occupied bed days, number of beds, occupied time, the number of days the beds were occupied. So that's the market share measure. You just square the market share measure and then sum it up for all the facilities in that market. Now, the HHI has some quite attractive property. It is a number ranging from 0 to 1. If you have many competitors, each has a very small market share, then your HHI is very close to 0, and you have a very competitive market. Now, if you have a monopoly, you have only one firm in the market, then obviously the firm's share is by definition 1, and the HHI is 1. That's a monopoly. So in this measure, the larger number indicates less competition or more concentrations. Now, the US Federal Trade Commission merger guidelines says that if the HHI is below 0.15, that indicates a rather competitive market. If it is above 0.25, it is a highly concentrated or not competitive market. If the number is in between, that's a moderately competitive market. So these are our competition measure. We will show you result using the most popular measure, the HHI, later on. Now, here we show you results of 6 quality measures. There are many other measures we use. You can find them in the reports, in the working paper we circulate. The first measure is the use of antipsychotic drug, and this is measured as proportion of residents and adjusted for case mix and excluding some disease. Second measure is premature mortality, again defined as proportion of residents, in terms of proportion of residents who die and considered potentially avoidable. The third measure is assaults per residents. These are reported incidents involve unreasonable use of force. The fourth measure is complaints per resident. These are complaints received by the Aged Care Safety and Quality Commissions during a particular financial year. The fifth measure is registered nurse hours. These are hours worked by registered nurse per resident per day. The sixth measure is total care hours. These are hours worked by direct care staff per resident per day. Now, the next measure we construct is a price measure. What we want to do is measure the price received by each aged care facility on average, because remember our unit of observation is a facility. We don't have data on individual consumers. So we look at the revenue data of each facility and we try to construct an average price. The average is expressed in per resident per day. So the price we construct, we use revenue data on daily care fees, which include mean tested daily care fees and extra service fees. And also we also include daily accommodation payment and the equivalent value of the refundable lump sum payments, RAD, RSC, and bond held at the end of financial year. So these are lump sum payments that consumer choose to pay to the aged care provider. We convert this into per resident day using the MPIR. The MPIR stands for the maximum permissible interest rate. These are interest rates set by the government, and providers use this interest rate to convert between daily payment and lump sum payment for accommodation payments. The last revenue source is a subsidy amount received by facility from the government. So again, this is converted into per resident per day. So we sum all these up and then we get an average price received by facility. The other covariates we use in the studies are number of resident places. This is a measure of size. So bigger size facility will have more resident places. Ownership type. So we have for-profit, government-owned, and not-for-profit. We won't show you detailed results of this ownership type. We'll just mention them later on. CIFA, which is the socioeconomic index of areas. These are area level measure of socioeconomic status, and these are data compiled by the ABS. And fourth is the small area dummy. So we are using SA3 dummy. And then the last is the year dummies. And I'll pass it on to my colleague Ove to walk you through the results.
Yeah, thanks, Jongsay. So I'm gonna start my presentation by showing you some colorful maps. So these maps are the aged care planning region maps for financial years 2008, 2013, and 2018. And so each of this colored block represents a particular aged care planning region. And the variation across the regions, the variation in color across the regions and across the years reflects the variation in competition intensity across the regions and the years. Yeah, again, the competition is measured by HHI here. So the darker the color is in a particular region means higher competition in that region. As you can see in all these three maps, so there's a huge variation in competition across regions, especially between rural region, regional regions and the urban regions. And this contrast between regional and urban tends to be quite persistent across the years. Also, after years of market-oriented reforms, which started in 2013, under the umbrella of Living Longer, Living Better Act, which aims to actually boost the competition in the Australian aged care industry. If you compare the map of 2013 versus the map of 2018, you can see that for some regional regions, we actually the competition actually has slightly increased. However, for most regions across Australia, the competition status tends to be quite stable, which means we don't really see much difference across the years for most planning regions in Australia. All right, these two graphs illustrates in principle what relationship between competition, quality, and the price we would expect to see. So here, competition is measured by HHI. Just remind you that more competitive market tends to have lower HHI. So take this one as an example. As the HHI decreases, which means more competition, we would expect to see, in principle, the quality increases. For the price, if we increase the HHI, which means the market is less competitive or more concentrated, we would expect to see the price goes up, right? So this is, in principle, we would expect to see. Now let's proceed to have a look what our data, what our regression tends to tell us. So these two graphs presents the estimate effects of competition on two quality measures, which are respectively the antipsychotic use and also the premature mortality. I'm going to explain in a bit more detail what are these lines and those represent. So each of these horizontal lines represent the 95 confidence interval, and the dot in the middle, the dot in the middle represent our point estimate from the regression, right? So if the zero is within this confidence interval, which means our estimate is not significant. And on the graphs, if you see this vertical right line, which corresponds to 0, if you see this line cut through the horizontal lines, it means our estimate is not significant. All right. And also, some of you might be wondering how we actually interpret our estimate effect. To interpret this effect, just give you an example here. if we increase the HHI from the base category, which is between 0 and 0.02, say, for example, to the highest degree category, which is larger than 0.6, which means the competition has substantially decreased. Our regression actually tells us the quality actually increased by this amount. So the distance between this dark point to this vertical line is the increase in the quality. So, but as you can see from these two graphs, none of these effects is actually statistically significant. So, from these two regressions, we actually there's no actually evidence showing that competition has significantly affected either of these two quality measures. Now let's now proceed to another two quality measures, which are respectively number of assaults per resident and also number of complaints per resident. Again, I think we see similar story here. All these red vertical lines cut through all these horizontal lines, which means no significant results at all. Let's now proceed to the last two quality measures. For the total care hours per resident day, the same story here, no significant results at all. However, for the registered nursing hours, we actually see some significant results. And in terms of the direction, say if we increase the HHI from the base category to the largest category, which means the competition has decreased, we actually see the quality, we actually see fewer registered nursing hours, which means lower quality. So a lower competition seems to see a lower quality. So the direction seems all right. However, unfortunately, this pattern is not quite robust. Remember, we also run our regression for another two competition measures, which are respectively the number of competitors within 10 kilometers, and also the distance to the third competitor. There, our analysis actually didn't produce any significant results at all for the RN hours. So we see, even though we see some significant patterns here, but this pattern is not quite robust across all the measures we considered. All right, this graph presents the effect of competition on price. Again, the same story here. You see this red vertical line cut through all these four horizontal lines, which means we don't observe any significant results at all. However, just for information, for the analysis we use in the other two competition measures, we actually see some weak significant results there. Showing that highly concentrated markets, which means the competition is quite low, actually see higher prices. So low competition, high prices. So the direction in the other two from the other two competition measures seems to be all right. Some additional results. As I mentioned, we ran our regression for the other two competition measures as well. So by and large, we see similar results across all these three competition measures we considered. In addition, we also compare performance of government-owned facilities versus for-profit and not-for-profit facilities. Just briefly summarize our results there. So for most quality measures we considered, it's quite clear that the picture is quite clear that government-owned facilities deliver much better, much higher quality of care than for-profit and not-for-profit facilities, which means the government-owned facilities perform the best. When it comes to prices, it's also very clear government-owned facilities charge the lowest price, followed by not-for-profit facilities. Just remind you that the price we use in our regression here also consists of the subsidies the providers receive from the government. All right, just briefly summarize our results before I hand it over to Jongsay. So as you can see from our estimates, there is no evidence showing that more competition is actually associated with better quality of care in Australia. And also, we see one exception is from the registered nursing hours regression. However, the results there are not quite robust across with other two competition measures. And also, we actually observe the competition is actually weakly associated with price, and more showing that more concentrated markets, which means lower competition, tends to have higher prices, which is consistent with the principle. Okay, now I'll just hand over to my colleague Jongsay.
Thank you. Thanks, all. So the question then is, why didn't competition work? That's $1 million question. There can be many reasons in this residential aged care market. For one, we need to remember that it is a highly regulated market. Maybe providers just do not respond to market forces, or perhaps they don't have to respond to market forces because there are so many different sources of market failures here in this market. I can name two which are quite obvious. One is we don't have much information on quality to go by. So when the consumers try to choose aged care facilities, there's not much quality information out there for their local market. And quality information tend to be quite inconsistent over time. So Australia is quite backward in terms of providing public information on quality of nursing homes. So unlike the UK and the US, both use a 5-star system of public ratings of nursing home facilities in their markets. So consumers just can go to the website, click on the area they are in, and then that will pop out a list of nursing home facility with all their star rating. And that's quite easy to follow which are the higher quality facilities. We don't have that. Now, the other problems in Australia is the price transparency problem. Prices are extremely complex to calculate. When I first look at the pricing information, I couldn't make any sense of it because it's so complicated. It also depends on mean testing and so on. So, and especially the use of lump sum payment in the pricing equations really makes things complicated. It's almost like trying to solve a dynamic programming problems here. So it's really hard to navigate the system. Now, if consumer cannot respond to quality and prices, then why should producer respond to market forces? There simply won't be any incentive for producers to do so. So I think these are the problems that give rise to the fact that competition doesn't seem to work in our aged care, residential aged care market. Now, what can we do? There are two options in my mind. First, we can try to make competition work better. So we need to address market failures. In this case, we can start, and we should start, by publish quality ratings of aged care facilities. And we should publish it in a way that's easy for consumer to understand. So a 5-star rating system would be a good way to start. Now, secondly, we need to simplify the pricing of aged care residential places. Now, we need to make price transparent, and easy to calculate so that consumer can do price quality comparison of aged care facilities. And thirdly, I'm sure in a lot of these markets, consumers would need help to navigate the system. So advocacy, it's a very important element in trying to help consumer access informations and use informations and to make consumer choice a more effective way of disciplining the provider and the market. The other alternative is to forget about market altogether. We don't need consumer choice. Let's set up some sort of national standards of care and try to categorize users into different categories, much like our hospital DRG system. So if you are in this category, you get this much funding. If you are in that category, you get that much funding. Quite similar to the DRG system we use for hospitals. We can try and supplement the system using some sort of pay-for-performance systems to improve quality. Just also, it's also very much like the hospital system we have. Now, personally, I don't think this sort of national standards would work very well. Now, by the way, this is also recommended in the Royal Commission's report. Now, the reason this is not going to work very well, in my mind, is because aged care is unlike healthcare. In healthcare, someone has a problems, we know how to fix them up, we fix them up, off they go. So there's not much consumer preferences involved here. I mean, if you have a heart attack, you've got a heart attack. So we know how to treat you, and you can't choose whether you want this treatment or that treatment. It's basically the doctors and specialists deciding on what to do with you. Now, with aged care, it's not the same. Aged care, in a lot of cases, it's about end-of-life care. So a lot of it is about daily living, things that we do trying to make life more comfortable and maybe more enjoyable for the users. So in that sense, preferences come into play in a very strong way. And I don't think government classifications of users would be able to take care of different preferences of users. So for these reasons, I think we should try and concentrate on making the market work better. We should try and provide quality information and also simplify pricing. I'll stop here. I think we got run out of time.
Great. Well, thank you, Jongsay and O, for that presentation. So a number of questions have come through while you've been speaking. Just a reminder that you can still post questions through the Q&A function at the bottom of the screen in Zoom, or the box to the right in Slido. I'll start with a few, I guess, clarifying type questions. In terms of constructing the competition measures, there's a question about how you deal with facilities in the same area who are owned by the same provider. Do you treat them as competitors, or do you, or how do you deal with that issue?
Yeah, we actually are not treating them as competitor. For example, if we in the measure, when we in the measure of the number of competitors within 10 kilometers, we actually exclude all those facilities under the same provider. So the same, likewise with the HHI and also the distance to the third competitor. So yeah, briefly, in short, we exclude those facilities within the same provider.
I should add that it's hard to know whether two facilities belongs to the same provider or not. So we are kind of doing a guessing job here, using their name. So for example, if their name is North Shore Aging Aged Care Facility versus Southside Aging Aged Care Facility of certain institutions, then we kind of guess that this would be the same provider.
Right. And also the Aged Care Commission provide us with a list of the correspondence between facilities and providers. But even their list is not 100% accurate, I would say.
Okay. And on the price measure that you have, there's a question about to what extent is there price variation within a facility, or do they tend to charge the same for all residents?
I think the price for fully subsidized residents would be the same, but there would be variations for residents who are partially subsidized and for those who are not subsidized. And also we have to remember that facilities also can offer extra services and additional services. So those who involve extra charges, and they are not subsidized. So that would create some variation within the pricing of one other facility.
Now, I've got a few questions coming through that are broadly around the measure of competition, or the measures of competition that you use, but not just about how it's constructed, but also, I suppose, questions about where the variation in, where you're identifying of the effects come from. Where's the variation in competition coming from? And are you concerned about, for example, endogeneity issues? The locations where, Catherine de Fontenay has asked, as posed pose the question, that locations where higher prices can be charged are likely to have more entry. And I was asking, could you proxy competition with density of population in a location rather than the measures that you've used? So, can you speak to the validity of your competition measures and in potential issues, endogeneity issues with it, and perhaps also just where you think the variation in competition is coming from that identifies your effects? So on the endogeneity issues, we obviously are not calculating the causal effect. Here we are looking at associations. We did have some results on using some instrumental variable methods. The results are pretty much consistent with what we found. So we're not terribly concerned about whether our results are way off the mark. Now, on the issue of entry, I think because the aged care places, the approved aged care places, so providers need to get those approved places through a bidding process. So it's not so easy for provider just to enter an area. They need to get their approved places first. So in that sense, entry isn't, in a sense, free in this market. So the effect of entry, it's quite small, I would say. Oh, you have anything to add?
Yeah, the same. I think the supply of these services, also the entry of the providers is quite restrictive. Capped by the government. So it's not really an easy process to easily go and come.
A related sort of question is, to what extent are you picking up effects of rural versus urban areas? Because that what's being asserted that people in or non-urban environments that tend to have lower competition. They also have lower prices. Are you picking up that that sort of regional dimension rather than a competition per se dimension?
Yeah, that's a fair question. We try as much as possible to control for it. So we do have the small area dummy in the regressions. So that would, to some extent, control for the rural-urban the differences. So we can think of these results as measuring competition within a small SA3 area level.
Yeah, in our regression, we control for the SA3 dummies, so effects. The graphs I show you is just from the raw data. So there, the variation, might be reflecting some regional effect. But in our regression, we actually control for the regional effect.
Right. And I think, Jongsay, you alluded to this towards the end of your presentation. Do you think that there are important quality dimensions that you're not measuring that potentially could be affected by competition style? I mean, the sort of things I might think about as the quality of the food or the general ambience of a place or something like are these things that that you probably would ideally be able to look at it as well as what you have done?
Well, sure. There can be many different measures of quality. So in the literature, we tend to use what the quality measures that people use in the literature. So one thing that we didn't use is the number of compliance failures, which we have data on this. But the problems with in the context of Australia is this variable is very much affected by enforcement changes over time. So there were enforcement changes on compliance, and that actually generate a lot of the variation in this variable. Now, other measures that we had also cover very, very different dimensions of quality. So in the report, we have quite a few more measures than what we presented here. But the results are very much similar. So you're not going to get different patterns here, I don't think.
Yeah, if I remember correctly, we actually look into, in addition to the 6 measures we report here, we also include another 6, I think, in total 12. So we actually explore an extensive range of quality measures. And as Jongsay said, by and large, the results are quite similar across all these different measures.
We are running out of time, but just one final question is there evidence from other countries that's either in line with what you're finding or contrary to what you're finding that you're aware of?
We did a survey which we just got it published in the journal, The Gerontologist. So our findings are by and large not very different from the experience of other countries, except I think in the US, they probably have more variations in their findings. So in the US, there are studies that show competition actually are effective in allocating resources in this market. So competition results in better quality. There's some study showing that, but there are also studies that show there was no effect, and some studies show there were opposite effects. Now, I have to emphasize that the institutional settings are quite different between Australia and the US. So it's very hard to try and draw lessons from other countries with totally different institutions.
Okay, well, we are out of time, so apologies to those of you whose questions I wasn't able to put to our speakers. They may, however, because we do have a record of those questions, our speakers may be able to answer those questions, and we would then post them on our website. So let me thank our two speakers, and also thank you, the audience, for attending this colloquium. I hope you've enjoyed it, and I look forward to seeing you at our next one on the 18th of May, when Dr. Antonia Settle will be presenting on the topic of whether the economic slowdown will have brought a jump in underinsurance. You can register for this colloquium by following the link that has, I believe, just been posted in the chat function in Zoom and posted next to the live stream on Slido. But until that colloquium, thank you and goodbye.
Thank you. Bye.